Okay, great. Okay, so looks like we've got a few people on here. And so welcome to today's webinar. My name is Erin Lynch. I'm the Director of Financial Services at the Nevada Hospital Association. And the purpose of the webinar today is to go over the required hospital quality measures that are assigned to your hospital for the Nevada Medicaid Private Hospital Provider Fee Program. And these measures are required to be reported on a yearly basis. This webinar is for the psych hospitals. And the measure for this type of hospital is hours of physical restraint use and hours of seclusion use. So as we continue our work with the hospital quality measures, this session is designed to ensure you have a clear understanding of the specific reporting requirements for this measure and to address any questions you may have. The Zoom is being recorded today and will be available on our YouTube channel and our website. And please note that updated templates were emailed out, and the only thing that changed about them was the instructions tab and how to submit your completed measure. And today we have with us Liza and Sherian from Mercer, and they're going to go over the quality measure that's assigned to your hospital type. So with that, I'm going to turn it over to Mercer.
Awesome. Thank you. Again, my name is Sherry Ann Thompson, and I'm a senior medical consultant here at Mercer. And I've been with Mercer for about a year now, but I've been a registered nurse for about 15 years, helping various states and MCOs with their VBP and quality measures. I'm accompanied here today by my colleague, Liza. I'll let her introduce herself.
Hello, I am Liza Ottorino. I'm an associate here with Mercer. I have been with Mercer, oh, th 3.5, I forget how many years. This is my second year on this particular project, so you might know my name from these submissions last year and this year, depending on if you've gotten them in yet. I am going to be turning my video off because I'm going to share my screen for the PowerPoint. My computer does not like it when I try to do video and share. But I am here. I'll just be off video.
All right. Thank you, Liza. All right. So again, welcome everyone to our session on the hours of physical restraint and hours of seclusion for the 2026 program year. Today, we're going to focus on how to ensure your reporting accurately reflects your facility's safety culture. While much of this information will be familiar to most of you guys, if you're a seasoned team member, this session could also serve as an excellent foundational training for your newer staff. And since we're recording the presentation, you will be able to easily pull this up and use it as a standard training resource for your future hires if needed. If you guys have any questions during this presentation, feel free to put them in the chat. We will have a Q&A portion where I'll talk about some frequently asked questions, and then we can address the questions at that time. All right, so hours of physical restraint and hours of seclusion are event measures used by CMS and the Joint Commission to track the total hours patients spend in restrictive interventions. We report these as a rate per 1,000 patient hours, broken down across 4 specific age groups, from children to older adults. Next slide. So why does this measure matter? Beyond being a safety indicator, these measures are a reflection of how well we respect patient autonomy and use evidence-based de-escalation practices. High rates can often point to underlying issues like staffing shortages or gaps in your clinical training. Next slide. Okay, so defining the population. For these measures, we are specifically looking at our Medicaid population. And so the denominator or the exposure rate is the total volume of care the denominator is the total volume of care in 1,000 increments, while our events or numerator are the total hours patients spend in the restraints or seclusion. Okay, so again, the denominator is the exposure, that's the volume of care in 1,000-hour increments, and the events is the numerator, or the total hour patients spend in restraint or seclusion. And then to the right, I have some definitions that will help you when you're pulling data and going through your measure logic. So again, this PowerPoint will be available to you to go ahead and read back. Next slide. The calculation is pretty straightforward. You take the total restraint or seclusion hours and divide them by the total Medicaid patient hours and multiply by 1,000. It's vital to remember to multiply your net inpatient days by 24 to get those total patient hours correctly. So the flow chart visualizes the two parallel paths for your data. So you have your denominator path for exposure, and then you have your numerator path for events. The process culminates in a single rate for each of your 4 age demographics to ensure precision in your final output. So then now let's talk about some best practices. Next slide. Best practices for data extraction. We want to look at 4 focus areas: standardized logs, stratification accuracy, census alignment, and real-time audits. Small errors in time tracking can lead to massive skews in your data because of that 1,000-hour multiplier. So we want to make sure that we're utilizing our best practices for pulling this data. Since we are reporting this data retrospectively, success depends on bridging the gap between real-time nursing documentation and your month-end data pool. We highly recommend using these 4 focus areas in order to catch any errors early. All right, so we want to make sure that it's okay. Make sure that we have a uniform tracking log. We want to make sure that the date of birth is correct, so we have that correct age demographic. We want to make sure that we're reconciling those nurses' census on a frequent basis and doing as many real-time audits as possible. Okay, next slide. And so I kind of briefly touched on it before, but just capturing pitfalls. We want to make sure that we are documenting. Failing to document the exact time a restraint ended, leading to a default in duration that may be longer than the actual event. So we're making sure that we're not failing to document the exact time, or we're documenting the exact time, so we don't have any missed release times. Forgetting to subtract patient leave days. Remember, that's really important. This can incorrectly increase your denominator and artificially lower your rate. Reporting minutes as hours in the CMS portal, which inflates the rate by 60 times. And then lastly, counting one event that spans 2 months in the wrong month's total. Minutes should be attributed to the month they occurred. Next slide. All right, so here are some frequently asked questions that have come up numerous of times in previous program years. I'll just read them off. And then also, again, if you have any questions, put them in the chat, or you can come off of mute and we can address your questions today. Which hospitals does this measure apply to? Erin mentioned that before. So everyone here should be a psychiatric hospital. So this measure only applies to psych hospitals and not hospitals that have psychiatric units. If a patient is in a restraint for only 5 minutes, do we have to count it? Absolutely. There's no minimum duration for these measures. Every minute of a physical restraint or seclusion event must be tracked and summed into the monthly total. And then lastly, we had 0 restraints this month. Do we still have to report? The answer is yes. Reporting a 0 is just as important as reporting a 5.0. It validates your de-escalation success.
Looks like we do have something in the chat.
Okay.
Are you able to see that, Sherry?
I am not.
Okay.
I think my computer is freezing. Hold on one second.
So the question is, would it count for PRTFs? Oh, Sherry, we might have lost your sound.
Did you hear the question, Sharian? It says, so would it count for PRTFs? I don't know what PRTF stands for, but whoever put in that.
Okay, I think she's trying to type a response because she's having some sound issues.
Oh, okay.
PRTF is a psychiatric residential treatment facility.
So this is just for the provider fee program.
Yes, I'm just trying to type it in.
There you go. Now your sound is back.
You can hear me? Oh gosh. The answer is yes. Yes, it would. Oh geez. Sorry about that. I was like, did I hit mute by accident? No, I'm not on mute. I don't know what happened. The answer is yes. Is there any more questions?
Nothing else is in the chat. If anyone else wants to come off mute and ask a question. Okay.
All right. So again, if you guys think of anything later, we are here to help you. If you have a state-directed payment question, that would go to Anne. If you have any issues with the reporting template, that would be Liza. And then any more clinical questions like the one today, that would be myself. And you can reach out to us directly via the email. There's no middleman. You can just reach right on out. And if it's a quick question, I'll answer you within 24 hours. If we need to set up a call, we can do that. We can do 30-minute one-on-ones if you're having a more complex issue. All right, so just some key takeaways. If you take nothing else away, remember that accuracy is in the minutes and your denominators matter. Tiny discrepancies in start and stop times can significantly impact your final rate. So that documentation, again, it's really important that precision is top notch here. All right. I thank you guys for your commitment to patient safety and accurate reporting for this 2026 program year. And if there aren't any further questions, I will turn it back over to Erin.
Great, thank you. So just thanks everyone for joining us today, and thank you ladies for the great presentation. And just a reminder, this webinar was recorded today, so we'll get it posted. And hope everyone stays safe. Thanks so much.
Thank you.
Good day. Take care. Bye-bye.
Thank
too.
you.